Thank you, John. It's an honour and a privilege to come to such a lovely city. Although I've only seen a little bit, I've had a fantastic time. So thank you very much for inviting me. Is that working? Yes. These are my declarations. I'm Chief Investigator for 3 trials using the Funciona laser at the moment, but I do want to point out that I only use the laser as part of my research. I don't use it in my private practice or routine clinical practice. It's only offered to patients who would suit inclusion into a clinical trial at this moment in time. So I work in Basingstoke. I'm a consultant gynaecologist with an interest in urogynaecology, and also run the research out of the University of Winchester. It's always very gratifying to come to speak in these lovely cities, and it's quite difficult when you come from Basingstoke to big up Basingstoke. Basingstoke is a relatively small town in the middle of, in between Southampton on the south and London. We have got a few things that we like to to say that Basingstoke have given to the world. So we brought you Jane Austen, the author, and those of you who are a bit more my age, Elizabeth Hurley. We're the home of Burberry. So Burberry was actually first started in Basingstoke, but for some reason they decided that Basingstoke wasn't quite the place for them, and they've now moved their centre up to London. But probably now, if you would come to Basingstoke, the most important thing and the most famous thing that we've got is the Bombay Sapphire distillery, and all Bombay Sapphire is actually made just outside Basingstoke, on the river where they used to watermark all the money for the UK and for passports, and so it's now they've got a fantastic distillery. So if you want to come and do some gin tasting, please come and visit us. So the use of laser is nothing new. It's been around for many years, and it's been shown that the potential for laser for collagen remodelling is quite extensive, and we see this in the skin. We can see it in the subdermal tissues, and it's been used safely in the aesthetic industry for many years. A lot of people say to me, "Well, what kind of laser should I go for?" And when you're classifying laser, there are 2 things to look at. Firstly, what's the medium that they use to create the energy for the laser? And the 2 main ones used in gynecology, one is CO2 and the other one is erbium YAG. Really, I don't think that that's the important thing. I think the more important thing is, what does that energy source do, and what effect does it have on the tissues? And so the CO2 laser has an ablative effect, and I'll explain to you what that means. And then there are different types of erbium YAG lasers. They've got ablative erbium YAG, and they've got non-ablative erbium YAG. So an ablative, the way the way we want to see the hypothesis, as it were, for how lasers work is that they create collagen remodeling, new connective tissue formation. And that can be done in 2 ways. The first way is by causing microablation, where the laser fires these tiny little microscopic holes into the epithelium of the vaginal mucosa and into the subdermis. And that creates a direct thermal injury. It kills that area of tissue straight away. And then you get the thermal spread, so you get some little bit more tissue injury just adjacent to that. And with that tissue injury, you then get fibroblastic infiltration, and you get collagen remodeling. So it creates sort of like scar tissue. The non-ablative erbium is just the Funciona laser. That works in a different way. It has a smooth mode where it gently heats up, and erbium has got a much higher affinity for water, which is what you see in the subepithelial mucosa, and so it heats up that tissue, and it's a pulsed effect. So it heats it, and then it stops, then it heats it a bit more, and then it stops, then it heats it a bit more. So it's this gradual increase in the thermal properties of the tissue, rather than an immediate blast of microscopic heat. And it heats up to around about 67, 68 degrees. 60 to 63 degrees. And at that temperature, it creates a breakdown of the intermolecular fibrils of the collagen molecule, and so you actually get shrinkage of the collagen molecule. So the peptides break down, they get shorter, and that happens almost immediately. And then over a short period of time, over days, you get a sort of a mechanical interaction as that shrinkage of the epithelium, it draws up the deeper tissues, and then over a period of time you then get subsequent new collagen regrowth. And so the two mechanisms are very, very different, and they will have different effects on the epithelium. And so for me, when Barry O'Reilly first came to me and said, "Are you interested in looking at laser? Are you interested in doing a study?" I always thought, look, laser is always ablative. Laser is destructive. I just cannot get my head around the fact that you're going to burn the vagina just for it to scar and then it's going to remodel. It just didn't make sense to me. Why would you damage something just to repair it? Far better that you try and sort of maintain it and improve it. And that's where the smooth erbium laser seemed to sort of... It made more sense to me in a theoretical point of view, but obviously there's no evidence for it, or there's very little evidence. When you look at the evidence, there's quite a bit of histological work that's now been done, both in stress urinary incontinence and in GSM. And Lappi et al., they looked at women with stress urinary incontinence and then took biopsies 3 months later and looked at the effect on the tissues. And they showed that there was an increase in the epithelial thickness, but there was also an increase in the capillary density. So you get sort of thickening, new collagen deposition. And then they did a subsequent study where they looked at markers for cell proliferation. And again, they showed that after the laser, 3 months down the line, 6 months down the line, you get new cell proliferation as well as increase in the connective tissue. So the theory for how it works in stress urinary incontinence is you've got a laser here that you insert a glass speculum into the vagina, and then the laser is transmitted down through, and it's a light, so it's just reflected through a mirror. And here they're treating the anterior vaginal wall, which is the suburethral hammock. Actually, most of the lasers that they treat all the way around the vagina and then concentrate on the anterior vaginal wall. And the idea is then that it will create shrinkage and new collagen deposition and strength in here in the suburethral hammock, which is the bit that you're putting a TVT, isn't it? It's what you're trying to recreate with a TVT. So that's the theory. And some of the earliest work was certainly in stress incontinence. Almost all of if you look at the trials, and again, there are trials that look for management of stress urinary incontinence, and then there are trials for the management of GSM, genitourinary syndrome of the menopause. The majority of trials for stress incontinence have been done with the Photona Erbium YAG laser, and the majority of the trials that have been done for GSM have been done with the DECA Mona Lisa. So this study, they took 175 women. Now they had both stress incontinence or mixed urinary incontinence, and then using the ICIQ short form, which is a standardized symptom questionnaire, they graded the severity of their stress incontinence, mild, moderate or severe. And it's most laser treatments, they usually get 3 outpatient treatments, usually about 1 month apart, give or take 2 weeks, and then they followed them up for a year. And at 1 year they showed that there was a significant improvement in the symptoms of stress incontinence, but if you looked at the women with mixed urinary incontinence, that was a much less profound improvement, but with very little or no side effects. Marco Gambiacciani, he's a consultant from Italy, and he has an interest in the menopause predominantly. So he took 205 women with GSM, but then looked at a subgroup of those with just stress urinary incontinence in SUI. Again, did the laser treatment with the Photona, but looked at them not only at 12 months, but at 18 months and 24 months as well. And again, the main primary outcome was the ICIQ short form. And again, they showed significant improvement at 12 months, but that by 18 months and certainly by 24 months, their ICIQ short form scores were returning back to the baseline levels. So it doesn't look like laser has got a prolonged duration of effect. I'm just showing you some of the key highlight papers, and then I've done a sort of amalgamation of all of them. This is Adrian Gasper. He's looked at what is a particularly challenging cohort of patients with stress incontinence, those with ISD. And I really couldn't work out how on earth you would improve ISD with a laser. And he's used intraurethral erbium YAG and a combination of vaginal. And he this one was, he got objective testing, and as well as ICIQ at 6 months, and showed significant improvements in patients with ISD. And he diagnosed ISD on low mid-urethral closure pressures, this works for this group of patients. This would be quite exciting because they are a very, very challenging group of patients to treat. This is a picture from a poster. This has just been published in the last couple of months in the Open Journal of Urology. This was a case control series where they took 50 patients and gave them laser. 50 patients with stress incontinence had a transobturator tape, and 50 patients had a retropubic tape. And interesting, looking at their 1 hour pad test, they had quite good 1 hour pad weight tests at baseline, and then they followed them up for 12 months, and they showed significant improvement in all 3 groups. I found this quite hard to sort of believe, to be honest, but they've got 12 months data on that. Similarly, I think they're still in the mild to moderate category of stress incontinence, and certainly if you look at a lot of the other studies when they classify mild, moderate, severe, the suggestion is that those patients who've got a pad weight test more than 25 grams are less likely to show benefit with a laser compared to those that have got a pad weight test of 0 or 1 gram to 25 grams. There's only been 1 RCT, and that came out of Adolf Lukanovic and a group in Slovenia, and this was really the pilot study for Barry's study. So this is 114 women where they randomised either to the Funciona laser or a sham. And this is the thing, with laser you can do proper sham, and patients will not know whether they're getting the laser or not. There are very few studies where you couldn't do a sham operation, you couldn't do a sham TVT or a sham mini sling. So this is it lends itself to that. And they looked at ICIQ form scores, PISQ-12 scores, and sexual dysfunction scores, and all improved at 3 months. So I've just sort of trawled through myself, going through all the literature in laser and SUI, and at the moment there's sort of 18 studies that are of any sort of size or quality. Still, the majority of them are only observational. Couple of case control studies, so like the T versus TVT, only 1 RCT, but in all it's about 1,200 patients that have been treated. The majority, I said, were with the non-ablative erbium YAG. 4 of them were for the CO2 laser, and only 1 with an erbium YAG from dermablate, and that's an ablative erbium YAG rather than a non-ablative. And I would warn you that when companies come to see you and say, look at this, look at that, look at their data for their laser, not what's been transmitted from some other companies' laser. I think if the mesh debate has told us anything, it's you can't use the 510K clause to say that your device is the same as somebody else's. If you look at the primary endpoints for all the studies, the majority of them are just symptom scores, so they're usually the ICIQ short form, or the King's Health Questionnaire, or the Australian equivalent of these. Only 2 had an objective pad weight test, and it's only the 1 hour pad weight test, and only 1 had urodynamics, and that was the Gasper study. Follow-up for the majority of studies is fairly short, 3 to 6 months. A few of them have got 6 to 12, and there's only a couple that go to the 2 years, and that's mainly the Gambia-Chani one. And we don't know what the effect of repeat treatments are, so patients may get an immediate improvement, and then they probably will need repeat treatments, and we don't know what the effect of that will be long term. And does it work for all? Well, as I think as that previous study suggested, that maybe it may not work so well with patients with mixed urinary incontinence, but it's only 1 study. The severity, I think, there are 3 or 4 studies have all said the same. pad weight test less than 25 grams, it works quite well, or mild to moderate on ICRQ short form. More than that, it doesn't seem to have an effect at all. We don't know if you've got concomitant prolapse, whether that's different. We don't know if you're premenopausal or postmenopausal, whether it's going to have a different effect. We don't know if you're a smoker, what your collagen remodeling capacity will be like. Probably a lot worse, as we've seen with mesh. So these are all things that really do make them a very heterogeneous group. Looking at GSM, so GSM is essentially what used to be VVA, vaginal vulval atrophy, in old nomenclature, plus some LUTS symptoms as well. Could the laser be an alternative to topical estrogens? And there are quite a few women who, despite the opinion at the moment is that topical estrogens are safe for women with breast cancer. There are a lot of ladies that don't want to or don't get the beneficial effect from topical estrogens. I think Stefano Salvatore's probably championed this and has done a lot of work with the DECA Mona Lisa. And he initially, his early study back in 2014, took 50 postmenopausal women who tried estrogen and hadn't got the symptomatic relief they wanted, gave them CO2 laser and looked at them 3 months follow-up and found significant improvement in their the visual analog scores and their vaginal health index scores, the 84% of women were satisfied with the laser. And then when you looked at sexual function in a slightly larger group, significant improvement in sexual function, and that 17 out of 20 women who were previously not sexually active due to atrophy syndromes regained a normal sex life. That's quite an impressive a statistic. I know it's a short-term follow-up, and I know it's in a small number of patients, but still it's a significant improvement. There's this group out of Australia. This was a 24-month follow-up, again using the CO2 DECA laser, and again showed significant improvement in bladder function and sexual function and symptoms of vaginal relaxation and prolapse, even at 24 months. And Marco Gambiacciani studied using the Fotona laser, again 24 months, but looking at symptoms of atrophy rather than stress incontinence in all 205 women. They showed a significant improvement in all domains at 12 months, but again after 18 to 24 months it had started to deteriorate back to baseline. I think there are always concerns about safety, but the safety does seem to be, the safety profile for laser appears very good. That's always a caveat, because I think when the meshes first came out, we all thought that the safety profile for TVT was really good. If you look on the MORD database, so there's been 2 studies, one looking at sort of deleterious effects of laser. The MORD database has very few, I think it's only 24 episodes of sort of adverse effects that are relatively serious, and still they're in the realms of sort of low degree burns and edema, nothing sort of significant or life-threatening. There have been a case control study of 4 patients who were admitted with symptoms of bleeding, but the majority of those, it was, I think, that they were resuming activity, quite rigorous activity, intercourse after laser treatment, that possibly they may have, if they'd have tried that, I'm not sure if that was as the result of laser or as though I've had my laser so now I can go back to normal activity. So it was there's not a lot out there to suggest that it is particularly dangerous, but we don't know the long-term effects. Some people have said to me, well, what about the risk of cancer? If you keep ablating the vagina and using it over and over again, is there a risk of cancer? Laser this is on the non-ionizing spectrum, so I don't think there is a risk of cancer. I don't know, but that seems to be the thought, that it's non-ionizing radiation, so it shouldn't do. And if you think about it, it's probably a lot less injury than having 2 or 3 repairs and then a mesh repair. If you think of recurrent vaginal injury causing long-term consequences. Interestingly, there's a few papers now looking at OAB, and if you think, well, the one paper said that the mixed patients didn't do so well. There's 2 other papers, observational papers, that suggested that it may help with OAB symptoms, and there's one case control study where they took 50 patients, had erbium laser, 50 had a B3 agonist, and 50 had an antimuscarinic. And they were then followed up for, I think it was 6 or maybe 12 months. And they looked at OAB symptom scores in all 3 domains of the OAB symptom score questionnaire, and showed an improvement, a similar improvement in both the laser, the B3 agonist, and the antimuscarinics, but with a lower side effect profile, obviously. So I can't work out the mechanism of action for that yet, but I think that's just one paper. There's some very interesting results coming out about lichen sclerosis. That is a mixture of both the treatment for that would be ablative and non-ablative. So you ablate the lichen sclerosis, and then you use the smooth mode of the Erbium YAG to create collagen remodeling. And this was a randomized controlled trial again. It was Adam Flukanovic and the team in Slovenia. And 50 patients were randomised to either corticosteroids or to erbium laser, and then followed up sequentially 3, 6 and 12 months. And they had photographs taken, histology taken at baseline and at follow-up, and symptom scores. And there was a correlation between patient symptom scores, histology, and what you saw on photographs. And that the laser did just as well as the corticosteroids, if not a bit better. And the investigators were blinded to the photographs, so they were just given all the photographs. They'd put those into order of how they are in their 3, 6, 12 baseline 3, 6, 12 months, and the laser ones were far more predictably ordered in the right order by the investigators compared to the corticosteroid group. So I suppose you've got to be doing something right when you get sort of 2 or 1, 2 or 3 opinion or reviews or meta-analysis or systematic reviews in the IUJ, all of them coming up with roughly the same thing, saying this sounds really good, it sounds really interesting, it's got a lot of potential, but we need more data. The data is very, very limited. It's single centre, it's small studies, it's short-term follow-up, it's all observational, and that we really need RCTs. And so that's where we are now. Barry O'Reilly as chief investigator for the first study, which I was involved with. We've now recruited all 125 patients. Primary outcomes are for 6 months. So, Joanne, I know you wanted to know the results. The last patients from the last 2 centres are being evaluated this month, in October. So I would imagine that Barry will be presenting that next year at the IUJ. And we've just started out on, again, with a similar collaboration of the group, looking at, because the inclusion criteria for the first study was all inclusive, all patients with stress incontinence. We're now going to narrow the inclusion criteria down, looking at patients with the mild to moderate on 1 hour pad taste and ICIQ short form. It's a sham-controlled study. We're doing it a 2-to-1 sham with a crossover at 6 months for those who are in the sham group if they want to. We're also doing a study on prolapse, and Linda Cardozo is looking at comparing a CO2 laser and the erbium laser for GSM. So those are 3 or 4 RCTs that will be coming out, and I know that there's some coming out of Australia as well. So I think the RCTs that everybody wants are coming. They're probably going to be coming in over the next 6 to 18 months. So where are we sort of with the role in surgery? Well, similar to what you've seen in Australia, the same things happened in the UK. This is our HES, so this is the national data, and we see that the mid-urethral tapes dropped, and colpos have sort of dropped when the mid-urethral tapes came in, and not really been adopted in vast numbers yet, and that bulking was going up. And this was the BSUG, so we got the British Society of Urogynaecology database. This is data from there, where every surgeon who's doing incontinence surgery should put their data on here. And again, we see a rapid decline in major surgery. And with the litigation that we're seeing, and the same thing with the Montgomery principle, which was a big ruling about, that's where I think the do nothing came from, is that Montgomery was Mrs. Montgomery, she successfully sued an NHS trust because she hadn't been told of, she was pregnant, she had diabetes, she had a macrosomic baby, She had a vaginal delivery. The baby had a shoulder dystocia and developed cerebral palsy as a result of the vaginal delivery. And she argued that had she been told about caesarean section or offered it, she would have gone for that, and that it wasn't discussed with her, and therefore we need to offer patients all alternatives. The first one being do nothing, and then every single alternative that you could possibly think of. And so we are now. I'm actually mentioning the trial to say there is a trial that you may be suitable for if you wanted to be included in it, because we think we should offer everything. This is Dudley Robinson's group, and it's similar to your the work about the pain and taking 2 days less time off work for pain. Similarly, Dudley looked at, well, do you want to be really, really dry, but you've got a risk of having to have a catheter, or do you want to be fairly dry but less chance of having a catheter? And patients were actually saying, well, do you know, I don't mind, I don't have to be completely dry, I just really don't want a catheter. So they would rather have a reduction in efficacy for reduction in comorbidities, which is what we're seeing sort of worldwide. And so is this the perfect storm for the laser? You've got the concerns regarding mesh. You've got surgeons that can't do anything anymore because all we were trained to do was mid-urethral slings. So there aren't many of us who can do lap colpers. There aren't many of us who can do fascial slings. Patients' expectations are changing. That we are. I think our counselling is changing. Certainly in the litigation that we're seeing in the UK, we counsel patients a lot more about the risks of surgery than the benefits, probably. And they go, well, I didn't realise it was all going to be like that. Actually, I'll put up with it. So they are also. I don't know about probably the same here. People are now going to the gym, they're eating healthy, they're doing their Pilates, they're doing their pelvic floor, they're thinking about looking after themselves rather than just looking for the quick fix. I want the operation so I can get on with my life. Patients are prepared to do things in a more long-term benefit. And our first doctorate is to do no harm, and the question is the laser the answer to it? Is it the answer to surgery? Well, probably not. But prevention is better than cure. And as we've got this aging population, if we start to think of the laser collagen remodeling, like pelvic floor remodeling, looking after your tissues, looking after your pelvic floor, rather than just thinking surgery's going to sort everything out for life. Even if you're the best surgeon in the world, your success rates will deteriorate with time, or your de novo urgency will increase with time, or your voiding disorders will come, or your pain may come 5 or 10 years down the line. We don't know what's in store for laser, but it may be an option. So in summary, I think lasers are promising in results in mild to moderate. No obvious serious adverse effects in the short term. We don't know about the long term. And really, we do need to wait and see what the results of the RCT are. I think it should be. I don't like the idea of this just being, well, you can't do any harm, just offer it to everybody, because that's when you will do harm. That's when you will have outcomes that patients are not satisfied, or patients will have comorbidities. And we need to manage our patients' expectations appropriately. The majority of studies that I've shown you, they're all observational, they're all small. The establishment are very cautious about advocating laser, and I think that's the right thing to be at the moment. We do need to wait till the evidence is there, but the RCTs are underway. And what we really want to avoid is this sort of, this design a vagina, rejuvenate. We need to distance ourselves from that. That's not what we're about. We're about looking after women. We're about improving quality of life. And I think that the problem is people who are looking to make a quick buck using a laser in an outpatient are going to give the device, the whole rationale behind it, the wrong name. Similar to what we saw with meshes. If you can do something quickly with a mini sling in an outpatient, that's not the way we want it to go. And we've seen the FDA have issued a warning about the use of lasers, and lasers in the FDA, they're only used for excision and ablation of diseased tissue. They are not at the moment approved for remodeling, and none of them are. We don't want to see the same thing happen that we've had with mesh. I think that lasers are promising. The problem is if there was one thing that fixed everything for everyone, we'd all be doing it. You've got to tailor your treatment to the patient, and so some patients may benefit from laser, some will need a mid-urethral sling, some will need a TVT, some will need a Culper suspension. One size doesn't fit all, and the saying, if your only tool is a hammer, then everything it becomes a nail. You've got to tailor the treatment to the patient. So you want the right treatment for the right patient, done by the right person who knows what they're doing. I think that all speaks for itself, really, just going over old ground. But once doing it, I think there's also a call now that we want a database if we're going to be using these things, and that all outcomes are audited in the long term. Thank you.